And it's merci. It's an absolute privilege and pleasure to be here after many years of not traveling. It's good to see us getting together again and talking and exchanging ideas again. I'm absolutely privileged to be able to present to you guys the work that I've been doing with robotics. And when I look back, this started in 2002, so it's over 20 years now of work, and I think it's just like yesterday. But I was asked to address the genesis, the state of the art, and where I see the future of this. In the spirit of disclosures, I do have relationships with each of these entities. I was one of the original inventors of the Mazor robot. I'm no longer affiliated with the Mazor team or with Medtronic, but I am working on other robots at this point in time. In spine surgery, for years, we've put up an X-ray. We look at the X-ray, we measure, we take our goniometers out, and we try to be as accurate as possible, but then when we get to the operating room, we end up using a chainsaw. We've not been precise. We haven't been efficient, and that's been one of the issues that we've had to deal with as spine surgeons. Now, for years, I've been telling my residents and my fellows that the decision is always far more important than the incision. And you're going to hear me referring to preoperative planning over and over and over again. That was the single biggest lesson that I learned over the last 20 years, is the value of coming to the operating room prepared with your preoperative plan. Because surgery is all about control. Spine surgery, you don't want to lose control. You have to have everything planned out so that you can do the right job, you have the right team, and you're successful at the end of it. Now, robots are here in all aspects of life. Everything that we are involved with today is being automated, automized. Our luggage at the airport's sorted by robots. We've got vending machines that robotically make our food. There's now pizza joints in the United States that are robotic pizza joints. And it's a gimmick, but it's a robot. It's a machine that's making your pizzas. So they're here to stay. Now, this is where it all started. In 2002, Professor Moshe Shoham and myself wrote a grant for robotic spine surgery. And what we conceived initially was placement of percutaneous translaminar facet screws using robotic technology. And we wrote the grant, and I completely forgot about it. And then 6 months later, Professor Shoham calls me and says, "Congratulations, we have $2 million to build a robot." I went, "Great, where do we start?" So this is where it all began. And we started with a small robot, and now we've got a big robot, and now we're going back to small robots for different types of surgeries and automating multiple different things. But this is what robotics has actually done for us. It's allowed us to boldly go where no spine surgeon has been able to go before. And I'm going to show you some of the cases and the evolution of what we've been able to do with this on the basis of the preoperative planning, the automation, and the precision. So I don't want to dwell on some of the advantages of navigation and robotics, but maybe just out of curiosity, how many in the room, just raise your hands, are using navigation right now as part of their surgical armamentarium? Good, it looks like about a third of the room. How many are using robotics right now? No one. Wow. All right. Well, the robotics, the advantages, you've got the preoperative planning, you've got the procedure time, you can facilitate the MIS procedures, reduce X-ray exposure, reduce revisions, and essentially it boiled down to accuracy. And I really don't want to dwell on all of these things, but the accuracy has improved. Now, a lot of people will say, well, what's the difference between 95% and 98%? Well, if that 1 or 2% results in a revision, that's an extra $130,000 US cost per case for revision right now. So it is a big difference. If you can eliminate one revision surgery because you preoperatively plan, because you do things better, you are going to save the patient the grief and there'll be an economic benefit. Now, how many in this room would go on an airplane if they heard that the pilot didn't do his pre-flight planning? If the pilot doesn't know how much fuel he has in the tanks, if he doesn't know how much payload, what the weight of the cargo is on the plane, or how many passengers on the plane, would any one of you go on that airplane with that pilot? No. But for years, we put up an x-ray and we tell the patient, oh, you need a T6 to the pelvis instrumentation infusion. They say, oh, okay, fine, whatever. And you don't show them a plan. You don't show them the bill of materials of what you're going to do. Those days are over. And now we've got to be much more precise with it. So this is what is going on now, the genesis and the future. And Shiraz Qureshi wrote a great article for the International Journal of Spinal Surgery. I was the editor of the special edition for that. But he paralleled the Industrial Revolution and the evolution of personal computers with what's gone on in spine surgery. And it was just a masterful paper, and I encourage everyone to look up that special edition and read the manuscript. But the Industrial Revolution happened between the 1700s and 1800s, where we went from skilled artisans to machine tools. As skilled artisans, we were doing things freehand. We were making furniture. We were building buildings. Everything was freehand. And the quality was never the same. One mason didn't lay bricks the same as the second mason. It was all different. And it was very, very labor intensive. But then we got into machine tools, where we've got work pieces and the tools are guided. And you're able to plan and execute with precision, and you're able to mass produce and improve the quality. So this is the spine robot revolution, and this is what started in 2002, where we transitioned from a skilled spine artisan to using the robotic tools. Freehand placement of pedicle screws. Again, as good as we all think we are, those screws don't always end up where they want to be. And it is very labor intensive. With the robotic technology, with the navigation technology, we can guide our instruments. We can pre-plan where we're going to put things. We can execute with precision, and we can improve the efficiency that we have in the operating room. So this is the current state. We've got navigation and robotics, and for many, many years, I've maintained that all these technologies are going to be combined, and that's what we see now. We've got navigated robotic arms, we've got guided robotic arms, and the next horizon with virtual reality and augmented reality, the only thing limiting us today is our imagination. We're in such a privileged position, we just need to take the technology off the shelf and figure out how to use it to the benefit of our patients. And the evolution continues, and here you can see how navigation and robotics have come together with this one technology. So what has been good? Well, we've been able to minimize the intraoperative radiation exposure. We've been able to improve the precision of our screws. We've been able to improve the pull-out resistance by virtue of better placement. We can improve the deformity correction. We can recognize subtle anatomic variants earlier before we even get into the operating room. It does facilitate less invasive exposures, and it does enhance the operative efficiency. So this is just a standard, straightforward case in L3-4 spondylolisthesis. These cases are a dime a dozen. You can see there's our MRI scan, quite substantial stenosis. And I wanted to do this in the least invasive way, rely on some indirect decompression, as well as get her fused solidly and reduced. So here's my preoperative plan, screws above, screws below. And if you look over here, there's a little orange line. And this line is into the facet joint on the contralateral side of where I'm doing the T-lift for this lady. So here's how we can plan it out with the T-lift. You can see how we can get the correction planned. And here's what it looks like in the operating room. so I can get things organized, I can get all my trajectories done. But this trajectory here is into the facet joint. And then I follow that trajectory and I can drill out the facet joint percutaneously. So I have my interbody implant, I have my facet joint, I've got my fusion, and then on the opposite side, I'm doing the less invasive TLIF. I can get that facet completely out and do my decompression. So here's her immediate post-operative films. You can see this is where I do the TLIF through. Here's where I drilled out the facet joint. And then here she is at 1 year's time, and you can see how she's done very well. So this is another case, again, trying to be more efficient, more precise in the operating room. This was a 19-year young female competitive gymnast who presented to me with 12 months of progressive back pain. And if you look closely, she's got this bilateral spondylolysis. And you can see here, clearly you can see the lysis through there. She was able to do high-level gymnastics, but now it started limiting her in what she was doing. Here's her SPECT CT scan. You can see the increased uptake. Here's her MRI scan. You can see she has got normal disc spaces, so I don't want to fuse her. And she's a gymnast. I don't want to violate her muscles any more than I absolutely have to. So here's my preoperative plan. I'm doing percutaneous PARS screws, Bucks type screws, and I am percutaneously drilling out and bone grafting the lysis itself. So here's what it looks like in the operating room. We've got her anchored, we've got her in, and you can see here, this is the trajectory going right down to the lysis, and the screws are coming one this way and one that way. So here's the intraoperative picture. I've got the screws across there. I've drilled out the lysis, and here she is at 3 months post-op, but here she is at 7 months, and you can see the screw across, and you can clearly see that she's gone on to fuse that level, and again, or to repair the lysis, I should say, not fusing the level. And we've done it all through percutaneous incisions, and she's back with her gymnastics now a year out from this. And here's her VAS and her ODI scores, so she's improved dramatically with that treatment. Now, this is the verification in the operating room to show that we are in the right spot. And what I do is a repeat registration, and you can see the green lines are my plan. The white screws, obviously, you see exactly placed where we planned them for her. Oop, you go back one, there we go. So this is now getting to the more complex cases that we can plan out. This is a 51-year young female with a cervical myelopathy and essentially a drop head syndrome. You can see the extent of the compression, but you can also see that she has no paraspinal muscle. She can't hold her head up at this point in time. So here's my preoperative plan, and I want the best fixation I can because she is osteopenic. So I'm using pedicle screws throughout the cervical spine. Again, pre-planning the placement of the screws. Here's the intraoperative picture. You can see all the pedicle screws placed. Here she is post-operatively. Here's her MRI scan with the extent of the decompression and restoration of her alignment. And you can see that we've got the screws, again, exactly where they need to be according to the plans that we're doing. This is now getting even more complex. So this is a 71-year young female who presented to me with essentially a large lytic lesion in her sacrum. She had a past history of breast cancer. She's also got all these degenerative changes, and at this point, she's just unable to mobilize. She cannot walk. So here's my preoperative plan for her, trying to rebuild, bridge across the big gap that she has, place screws into whatever good bone I can find, do a decompression, try to spare the nerves, the sacral nerves for her. And these are the intraoperative pictures. So you can see partly percutaneous, putting the sacral rod across the sacrum. You can see here I've got my screws in place, and with the precision, I can drill right across and then link my rod right through the iliac wing, right through the sacral spinous process onto the opposite side. And then I can also get the screws bridging the gap, and then I just cleaned out, debrided the whole big lesion and just packed this all with bone graft and demineralized matrix and filled it up with whatever we could for her to hold it as solid. And here's the final pictures. And here she is at 1 year's time, all held together. And the interesting thing was, this was not breast cancer. This ended up being a high-grade B-cell lymphoma. So she also got radiation for this and subsequently did very well. She lived for another 3 years before succumbing to some heart issues. So here's the kids now. The 16-year idiopathic scoli, very rigid curve. You can see how we've got multiple levels here. There's the preoperative CT scan. But this is the importance of the planning. So I can take this curve and I can build it any way I want. And you can see here I want to give them a little more kyphosis, coronal plane. We correct it out. And here's what we're trying to achieve. And we've got all the parameters here, so we know exactly what we're going to do in the operating room. Here's what my final result, what I want to be. Typically, I'll plan one level above, 1 or 2 levels below, just in case I lose fixation. But here's the surgery. Very straightforward. Take him to the operating room. We've got the plan, and we're able to achieve the outcome that we were setting out to achieve. Now, we looked at the value of preoperative planning. We've published on this a couple times now, but this was the first 28 patients where we looked at what I was able to recreate in terms of the coronal cob and the sagittal cob, and you can see we're pretty good. I typically plan to get perfectly straight, but on average we got down to about a 7-degree coronal cob. Regaining the kyphotic abnormalities, we're able to increase it. We planned for about 26 up to 25. So with the planning software and with the robotic guidance, I've been able to get within 7 degrees of my coronal plan and 10 degrees in the sagittal plane. Now, is that perfect? Not yet, but we're getting there. We're able to do things better at this point in time. So here's the workflow, the preoperative surgical planning, where we segment the spine, we place the screws, and then we take that plan to the operating room so that the whole operating room team knows exactly what we're doing, what sizes, the length of the rod, what needs to be prepared, so the surgery becomes that much more efficient. But what is it that really matters? It's really the patient objective functional outcome. That's the issue, is the patient doing better, not what the x-rays really looks like. And this is a case that I like to show where I think the combination of robotics and at Texas Back Institute, we have a gait lab. We measure the functional outcome of these patients, comes together and really helps us. So this was a 56-year young female with tremendous low back pain, bilateral lower extremity radiculopathy and numbness, really had difficulty mobilizing, walking. I send all our patients at Texas Back Institute, we send the vast majority of patients for a pre-surgical psychological evaluation. And you can see that the psychologist tells us that based on this screening, the patient is clear for the surgery with fair to good psychological prognosis. But he also comments, patient believes that she cannot be helped. Patient tends to brood and ruminate about her problems. The MMPI, which is one of the questionnaires, shows elevated sensitivity to pain, feeling, and helplessness. But the psychologist tells me that, yeah, the issues are there. They're not that intense that you shouldn't operate on her. So we go ahead and we still operate on her. So here's my preoperative plan for her. Pretty straightforward again. I did her T10 down to the pelvis, locked her in place. It was my typical staged procedure, anterior interbodies followed by posterior instrumentation and fusion with decompressions and Smith-Peterson osteotomies. Here she is pre-op. Here she is 1 year post-op. X-rays look great. She is so unhappy with me. She's just, and here's her pain scales, and here's her Oswestry Disability Index. Pre-op, post-op, 1 year. Same scores. Didn't make her better. But then I show her her gait analysis, and this is her walking before surgery And here she is at 12 months. Substantial difference. And we measure multiple different parameters. So her cadence improved dramatically. Her walking speed improves dramatically. Her stride time is less. Her step time is less. Stride length is much better. But this is the real important thing, the balance analysis. When you look at her before surgery, if you look at the bottom here, she is wobbling all over the place. She is struggling to maintain her balance point within Jean Dubosset's cone of economy. But after surgery, look at how narrow she is. So now I show her these results, and all of a sudden, her psychology completely changes. So marrying the robotics to get the result and showing them what they can do with objective functional outcome measures has really changed the way I deal with patients and has helped me with these types of issues. So navigation robotics, what does what best? Navigation aligns you in the 3D space. It does position you. It can verify your position. It does help with some of the decompressive work, particularly with some of the tumors. Robotic guidance, drilling the holes, positioning to cut bone, actively removing bone now. It facilitates the surgeon's preoperative plan. But there have been challenges, there's no doubt about it. Navigation, the registration is global, and you're married to that tracking system and the reference array. If it's bumped, if the camera's moved, you've got to sometimes start all over again. It becomes very inefficient with that. And the error of accuracy with the navigation is 3 millimeters. And that may not be enough as we start to do more complex, more precise surgeries. Robotics, open cases, there's soft tissue pressure that can deviate the robotic arm. Registration in obese patients and osteoporotic patients with fluoro to CT registration can be difficult. And you really don't have the real-time verification, so you still do need to take an X-ray. But this is where the combination now of different technologies, I feel, is really going to change. And here we're back to the evolution of the personal computer. You may be familiar with Moore's law that dictated the doubling time for transistor power. We've seen miniaturization occur over the years, from large computers to small computers, big cell phones to small cell phones, the internet connectivity. And now the next level has been the apps, the applications that we use. Today I walked down to the beach on Nice this afternoon, and I had my Google Maps out, and it steered me right through all the points of interest. It was brilliant. Much more precise, much more efficient. I didn't get lost. I got back here in time to give my talk. So spine robotics, it's more efficient and is becoming less expensive over time, just like our cell phones, just like our computers. We're going to have big robots for big surgery. We're going to have specialized small robots for small surgery. We're going to have procedure-specific robots as well. There's going to be things that we can do in robots that can work beneath the skin, steerable robots. All these electronic devices, they're going to be connected, and we are going to be able to use these with remote access. And we're going to be able to do intraoperative and postoperative data sharing. If I want to ask Jean-Charles Louek for help in the middle of a case, I can call up and say, hey, look at your screen and see what's on here and tell me what to do. And we're going to have these procedural apps which are going to help us define the surgery and marry that again with the patient's clinical outcomes. So to summarize, the robotic advantages, we're going to minimize the intraoperative radiation exposure, improve the screw pull-out placement, revision, pull-out resistance and deformity correction. The preoperative planning aids in recognizing these subtle anatomic variants. We can facilitate less invasive exposures, and we increase our operative efficiency. But I've always said that robotics and navigation is not going to make a bad surgeon good. What it does is it makes a good surgeon more efficient and more precise. If you don't understand the anatomy, If you don't adhere to the indications, it doesn't matter what tool that you use, you're not going to do a good job for your patient. So the lessons I've learned over the years: preoperative planning, operating room efficiency, and recognizing those subtle anatomic variants. The radiation exposure is far, far less to the OR team and the patient and the surgeon. And the magic of the technology. I know today that I am a better surgeon than I was 10 years ago and 20 years ago because of this technology. And I also know that all the young surgeons out there are going to be far better than I am right now because of their experience with it and adding more ideas to what we can do. And then there's the future potential. And this is some of the stuff that I'm working on now, where we're integrating semi-active and active robots, where we can go in and plan out exactly where we're going to do the decompression and use different tools to facilitate that decompression to ensure that we're doing the job that we need to do. So what is the future? Patient-specific plans and implants, potentially accompanied by disposable instruments with just-in-time delivery, performed in an outpatient center, using the most appropriate, least invasive access, facilitated by robotics and navigation, providing a predictable outcome for our patients. And with that, thank you for your attention. I'd be happy to answer any questions. It's all as clear as the blue waters off of Nice.
Isadore, I'd like to congratulate you for this very clear and very brilliant lecture. I know you since many years, some years now, and I know your involvement in increasing efficacy and safety of our surgery. Just a question for you is, you know that we use simply free hands, just a man. We have the feeling of what we are doing. And does a robot can have this new aspect of what is he doing, that you know if the reference is not so good, there is a risk of doing automatically a wrong thing without any control, theoretically. And my second question is about, as you know, we are very involved in control of correction of deformities. And do you think that the robot and all different kind of simulation can have some new development on the aspect and the ability to control what we are doing during the surgery? The robot is able to place properly and is the best and most safe condition pedicle screws of implant, but control the correction is another aspect of the treatment. Thank you.
Yeah, Danielle, thank you. Thank you very much for the kind words and for the two questions. With regards to the first question, there is an emotional aspect to being a surgeon and teaching others, and the haptic feel and what we do there. And I'm frequently asked, you know, the guys you train now, are they going to be able to put in a pedicle screw freehand? And there are multiple arguments to that, going examples such as laparoscopic cholecystectomy. Today, a general surgeon doesn't know how to do a laparoscopic or how to do an open cholecystectomy because everything's done laparoscopic. Likewise, knee arthroscopy. There isn't an orthopedic surgeon today who's trained on open knee meniscectomy. Everything's done arthroscopically. So I think we're going to see that evolution. I'm also pretty much convinced that over the next 10 to 15 years, the answers for spine surgery is not going to be heavy metal. We're going to have different techniques and biologics and predicting things. But with respect to the haptic feedback and feeling it, there is a difference with robotics, but it's a different skill. It's just like the open knee surgeon who's now an arthroscopic knee surgeon. There still is a feel. It is a little different. But on top of all that, we're going to have other technologies So what we lose with the haptic, with the feel, we're going to gain, and particularly the augmented reality, where we're going to overlay, we'll have a heads-up screen of some sort, and there's different technologies that are just coming out right now, so you're going to be able to see it live as opposed to navigated, which is still not a live approach to things. So there's a lot of discussion that can go around that. It's an evolution. I do believe that it's an evolution in the right direction. With respect to your second question on controlling deformity, I do think we're going to have a mechanical way to do that. The key to deformity correction, or the keys in my mind, are where you place your screws and how mobile you make the spine, the osteotomies and what you do to get things loosened up so you can move the spine in three-dimensional space. If you preoperatively plan that, we will have a machine someday that's going to do that for us. We're not going to have to derotate rods and distract and compress and laterally translate. The machine will do that at some point in time.
Yes, thank you. Thank you for this brilliant lecture. I'm neurosurgeon Richard Dassaker from France, Lille, and I might have the robot in a few months. My question to you is, how could you make sure that the non-surgeons one day will not place screws with robots?
We have to form the spine surgery police force. This is actually, it's a very big problem, and it's actually already happening in the United States. And I don't know if you saw the North American Spine Society release, actually the North American Spine Society didn't, but it was the American Association of Neurological Surgeons, American Academy of Orthopedic Surgeons, and a couple of the other societies released a position statement that non-surgeons should not be doing fusions. Because in the United States we have anesthesiologists, rheumatologists, and now we've got neurologists that are starting to do surgical procedures with the technology. And it is very, very scary. I've been of the opinion that if you're going to do something, you have to know how to get into trouble and how to get out of trouble. And the anesthesiologists and the rheumatologists don't know how to get out of trouble when they try to do a facet fusion with a dowel and they're drilling a hole through the facet joint and they don't quite know where they are or what they're doing. So it's a problem. I believe it's the societies that have to speak up and come out with guideline statements and prevent those that are not adequately trained in spine surgery, those that do not know how to deal with the complications, keep them away from the patients.
Thank you, Isidore, for your presentation. And to go in the same direction as Richard, if you do a perfect planification and the robots put the screws as according to the plan, but unfortunately, one screw is outside the appropriate direction, and the patient has paraplegia or what else, who is responsible? Is it the company, is it the robot, or is it the surgeon?
Another brilliant question and issue that as spine surgeons we have to deal with. We are the ultimate responsibility. It's the spine surgeon's issue. It's not the company's issue. It's not the robot. The robot's an inanimate object that we direct, in fact. It's our responsibility. You have to make sure you understand how the robot works. You have to check, double check, triple check. You cannot take anything for granted. You have to be vigilant still. Check your x-rays, know where you're going. And yes, there have been problems with the robots, just like any other technology. So this, again, is where I feel that the combination of different technologies, the more overlap, the more protective mechanisms we have in place, like navigation, like robotics, like augmented reality, like neuromonitoring, all those things combined are going to keep us as safe as can be. But it is still ultimately our responsibility. We're the ones that still hold the knife.
Easy. Do you recommend the robot to an old surgeon like me, who doesn't understand anything in technology, in internet, and so on, and because he has children, he can follow, but alone it's difficult. It's not better to carry on with hand? No?
It all depends on what you feel is best for your patient. Yes, older surgeons, more mature surgeons may not be as adoptable to this, as acceptable for this. Young surgeons, I think, are growing up on this type of technology. So would I recommend it to you? Yeah, I'd say you should look at it, try it, see if you think it can make you better. Work with someone who's got experience with it, and then you decide, is this an addition to make me a better, more precise, efficient surgeon for what I do, or am I still okay right now with what I do? I don't know that I would ever put in a cervical pedicle screw freehand. Now I put in cervical pedicle screws routinely with the robot. And it's changed the way I deal with cervical deformity. So for me, I've adopted it. That's come on board. That's my standard right now. Likewise, doing sacral reconstructions and placing screws. Those are tough to do freehand. For my practice, where I see a lot of these sacral reconstructions, it's changed. I don't know that I could do it without some kind of robotic technology today. Yes.
Madame Blanc from Lyon, France. Thank you for your lecture. My question is about this new generation that is going to use these technologies quite often and will be trained on these technologies. How do you handle the way you are doing the education of the young ones when they're used to have these robots in OR? Should we always have the two ways of teaching, or do you think that there's no problem to switch when you're young from the robot to freehand, or when the technology is not available?
Thank you for the question. So today at Texas Back Institute, I've got 26 partners. About half the partners use navigation and robotics, the other half do not. So our fellows get exposure to both. In my operating room, it's exclusively robotics right now. That's where they get the exposure. This will be an evolution. There's no doubt that it's going to change the way we do surgery. Today, I still believe that we have to be teaching open anatomy, open pedicle screw placement, open corrections of the spine, open cervical thoracic. I still think we need to teach people how to put hooks and wires in. But 10 years from now, I'm not sure we're going to need to do that. I think we're going to have developed better techniques, better things. I know what I'm doing today, 10 years ago, I thought was science fiction. But I know 10 years from now, when I look back, I'll say, boy, that was primitive. Look at what I can do now with these things. So the evolution's going to come. But today we still should be teaching the full spectrum. And there are a lot of simulators available now, too. We've got simulators where you can teach how to put in pedicle screws and teach how to use robots. So there's a lot of tools to enhance the education of the younger surgeons. But it always still boils down to experience. You still have to do it. You can be on a simulator all day and all night, but until you're in the operating room with that patient, you still need that experience.
Philippe Charles from Strasbourg. Thank you very much for your brilliant lecture. As far as I understood, robotics is mainly used to place screws correctly in the place that is desired. You've briefly touched on virtual reality, and there is an application that is coming up on tumor resection and localization into anatomic spaces to have a more 3D perception of the intraoperative field. Do you think that there could be a link between both technologies enabling more precise tumor resections? Do you have any experience with that? Is there something that you know about that?
Yeah, absolutely. There is going to be a link, and it will be a very strong link, precisely for what you mentioned. Tumor resections, when you're working around the corner through a minimally invasive corridor, if you've got that augmented reality, you know where your instruments are going to be and where you're taking out the tumor without banging into the spinal cord. And we have done a couple preliminary cases using the Augmetics device. I don't know if you guys are familiar with it here, but that's one of the heads-up displays which gives you that virtual reality. The limiting factor right now is the tools. I can look around the corner with augmented reality, but I still can't reach around the corner. So the tools have got to change also as we do it. So the preoperative planning, the execution and removal of bone with the robotics type device, the augmented reality to ensure that you're removing what you're removing manually if you need to, there's going to be a big link, and we're going to be doing it through less invasive, minimally invasive corridors with direct lines to the pathology. Well, wonderful. Thank you very much for your attention. I've really enjoyed it.